All right, let's go ahead and get going. Again, thanks for joining me today. I'm Eric with Motion Guidance. I'm coming live at you from the Denver, Colorado area in US of A. It's a real nice day outside. We've had some smoke and things like that recently, but starting to clear up. So today's topic is head and neck joint position sense error assessment and training afterwards. And most of this topic is built around the research that was published in 2003 by Trevelyan and Joel about joint position sense error in the whiplash-associated disorder population. So the reason for joining the live stream today and us shooting out this information is how to utilize this research and others like it in your particular clinic setting or your training setting, your gym, whatever it may be. A lot of people with recent events are starting to do some more in-house type of assessment and treatment with people. And so our clinician kit being portable, this allows you to do this just about anywhere. The things that you'll need in the clinician kit to get going with this type of assessment and treatment are going to be your laser, right? So of course you'll need that, and so we'll bring out the clinician kit laser here and a quick review on that. As we look at this is part of our new generation model. Remember, it has a flat button in the back, so you're not going to hit it accidentally to turn it on and off. When we turn this on, you'll see this project behind me pretty easily with the green laser, so you'll be able to pick up on that just fine. You'll need the perpendicular mount here, okay? And remember, when we put this on, you're going to want to slide that to the side and pop it on that way, and then roll it up to the top. Okay, that's how we mount that laser. And it has the teeth in the back that you can see there, and that's going to go on that yellow field, or in the old model, might have been a blue field there to go on your strap. I recommend using the second to largest size strap for this assessment. So especially with our new generation, this just flosses through, and then you bring that around and you can Velcro that on. And usually that allows for a comfortable adjustment for any size head, or if they're wearing a hat, you can keep the hat on for training and things like that. And that would just go right on their head. And with those teeth, we're going to have you slide those on there, okay, like that. So that's how we put together the setup for the laser. And with our clinician kit, you're going to be using our motion maze, because we standardized that based on the research that I mentioned earlier from 2003 to do just this assessment. So if we look at that research as well as some systematic reviews afterwards, there are some limitations when we look at how to do this across all research published articles. Not everything was homogeneous with the population and the setup and how many repetitions. So I'm going to summarize these for you and give the recommendations and the variations as we kind of go along here. But we'll try to standardize how you want to at least set it up in the clinical setting with your resources versus what they did in the research, and try to see if we can diagnose some joint position sense errors at the head neck. This is common in publications with the whiplash-associated disorder population that I mentioned, the chronic neck pain population, as well as the concussion population. So these are all people that when they come into your clinic, you'll want to think about assessing joint position sense error at the head neck. Obviously, changes in joint position sense error can lead to chronic muscle strain and poor muscle reaction. They'll lead to potential dizziness, circular nystagmus things, just the feeling of dizziness or giddiness around the head neck. You can lead to ocular motor changes, things like that. So it's definitely worth looking at joint position sense error on your patients. If you neglect to do it on the initial visit and you're not progressing, you might want to go back and look at it later for assessment of them based on lack of progress. Okay. So the general setup, we're going to want the patient 5 feet from the target, And I'll roll a video here pretty quick, looking at the summary of this and the whole setup. We can talk through it together while we're going through that. But 5 feet from the target, and you'll see the target when the video comes up is in the center of that motion maze. And that's a standard deviation target that we've calibrated for you. So the idea with the standard deviation is that if the laser is inside the standard deviation, that's considered normal. It doesn't matter if it's bullseyed, it doesn't matter if it's just on the rim. Anything inside that light blue circle is going to be appropriate for being inside the standard deviation of normal. Anything outside that circle is going to be considered an error if you're set up at that 5 foot mark the way we have it calibrated. The 5 foot mark is going to be where the posture of the patient is. So you're going to want to have them sitting in a supportive chair. They're going to have an upright posture, and they're going to be looking at the middle, and they want to maintain that posture throughout the whole treatment and testing procedures that we do. So make sure that that's standardized in your clinic, or if you are in a remote type of setting, make sure you always manage to measure out 5 feet from where the target is hanging for that. Once the setup is achieved, then you can you can ask the patient to look directly at the middle of the target after they've assumed good posture. And then you turn on the laser and adjust the laser to where it's pointing toward the center of the target. So don't have the laser on ahead of time and then have them try to center it. You want to hold on to the mount and then center that laser so it's at the middle of the target after they're sitting upright. Once we have that calibrated, the research from 2003 allows us to give 1 practice rep, so they can look over either shoulder. When we're always going to test both sides. So when you're looking over one shoulder, they go as far as feels comfortable with their head and come back, and the laser with their eyes open is going to be centered on the bullseye. After that, we're going to want them to close their eyes, look as far as is comfortable over toward one side, keep their eyes closed, and then come back to where they think is the middle of the target. When they think they have the middle of the target, they can let you know as a clinician, hey, I think that's the middle, or there it is, something like that is what I use in my clinic. And then I record whether they're inside or outside that standard deviation. If at a maximum of 6 repetitions, if they are outside of the standard deviation 3 times, then they have a joint position sense error based on the literature for that particular motion. Rotation has been the most highly researched motion at the neck for that, but there is some corresponding research with flexion extension as well, and we'll talk about that later for even adding things more dynamic like quadrant motions. Okay. Once you do one side, then you have to recalibrate, have them adjust their posture again with the laser off, turn the laser back on, put that back in the center of the target. They get 1 repetition of practice toward the contralateral side. They come back to the middle, see that the laser's in the center of the target. They close their eyes and keep it closed all the way through the full rotation to the other side, and then coming back to where they think is the middle. They let you know that that's where they think the middle is, and you record that data. So if a person is going through these repetitions and they get 3 repetitions toward one side that is outside the standard deviation, you can go ahead and stop testing. And I suggest that you do, so there's a reduction in learning if you're going through further repetitions. And we want to try to minimize that until the learning happens afterwards for training. So we just want to have the pure assessment. That brings up another point. I would not encourage too much verbal communication from you as a clinician about what you're trying to achieve. So we're just going to start them and say, hey, this is the center of the target. Look right, come back to where you think the center is, and tell me when you when you think you've achieved that. Don't go into the explanation of I'm looking for you inside this standard deviation, or give them encouragement to try to find the anything but the center, because we don't want them to be savvy to trying to cheat either by squinting and opening their eyes a little bit, which is common, especially with your youth athletes. And we don't want them to have a great understanding of what we're trying to diagnose. Sometimes too much explanation on the front end can mix up the outcome that you're trying to achieve. All right. So let's go ahead, and I'm going to share my screen and show you the video of how we want to get this done. And this was recently taken from a patient that's in my clinic. He gave me permission to share this. He does have a cut on one of the back of his ear, so he's just wearing a bandana in my clinic. Everybody that was approved, he's also been vaccinated. But he had a stroke, a CVA, which likely was corrected by the typical drug that they give within their window of a few hours of him noticing his symptoms. And so he just has a few things left over. He complains of ocular motor signs of getting fatigued when he's sitting at a computer. Sometimes when he's walking, he feels light dizziness and giddiness. And we had done this testing 6 weeks prior, and we had done some training. And so he was familiar with the test. But the things that he was starting to describe as his symptoms were ramping back up made me want to go back in and test this again. So that's another clinical scenario that you can use to utilize the motion guidance device for joint position sense error testing. So let me get in here and share my screen. And I'm going to share the entire screen here. So that's going to give me a little bit of a advantage for us as we go through. All right, so let's just expand this all the way. So I hope you can see that. So as we go through this, I'll be able to stop this periodically. But so here's the setup. So we have the motion guidance strap, that second to largest one. He put that on himself. I just guesstimated the distance, and he said it was snug. If you need to readjust that while it's on, that's fine. He does not have to have the yellow sleeve directly in front when he's doing this particular assessment, because that's the beauty of the ball and socket design of the laser, is that we can do a swivel to find the center. So if we start this video here and we say, okay, are you looking at the red dot over in this area? He says, yes. I turn the laser on, and then I calibrate that down to the red dot. All right. So once we have him centered up, he gets one practice rep. So his eyes stay open, he starts to turn, and he's turning his body here a little bit. So I say, I don't want you to turn your body at all. I just want you to turn your head. All right. And so you can allow for another repetition of that if you want, or you can go into eyes closed training and have him come back to where he thinks the center is. So in that case right there, he was outside the standard deviation. And so I record that as one outside the standard deviation, and he does this again. So he came back, he's still outside the standard deviation. So that's 2 reps that he does not achieve inside the standard deviation that is calibrated. And then of course he tries to adjust for that, and he's off. So he already has 3 repetitions outside the standard deviation. And so he's going to be positive for a joint position sense error for that. So then we move on to the left. So he gets an eyes open repetition, comes back to the center. He closes his eyes. I request he keeps them closed, and he goes toward the left, and he tries to come back. Okay, so he's outside the standard deviation there. And then your patients will do something like what he does, is he starts to say, well, I think it's over here, but let me keep my eyes closed and make a little adjustment. So he overshot that one. So that's 2 repetitions of eyes closed outside the standard deviation, and that one was inside the standard deviation. So now we have to go through more repetitions. So we have 2 outside, and now we have 2 inside. He almost bullseyed that one because he felt like he was trying to get a sense of what was being achieved back to the middle there. And he thinks it's there, and that's right on the border there. So I went ahead and gave him that one. So we did a 6th repetition. And there's a 4th repetition of inside the standard deviation. And so that is going to be a negative joint position sense error testing with left rotation for this particular individual. So let me stop sharing my screen here so this illusion gets out. All right. So from that scenario, we know that he has a high likelihood of having a joint position sense error for right rotation at his head neck area. And we want to go through training of that. So training is going to consist of doing repetitions in the clinic. And this is what's not clearly defined in the literature. This is kind of all over the place with how many repetitions people are doing and the what you're trying to achieve. For me, clinically, what I'm trying to achieve is have the patient have an understanding, one, that they have a dysfunction, that they have a challenge with right rotation, and that we need to correct that. But we're going to train for both sides just to make sure, so he has full available motion with good proprioceptive feedback. But I'm going to give him 10 repetitions that he has to achieve in my clinic where he is inside that standard deviation. So if he is going through training and he's outside that standard deviation, then he is going to have not to count that repetition, and we're going to keep going until he gets 10. And I explained to him that it just has to be inside that circle. It doesn't have to be bullseyed. And I would say that there's a 90+% chance that your patient is going to improve just within one session of trying to achieve that. Very rarely do people not get an awareness of what's going on and start understanding what's happening there. One other caveat, in the literature, people are typically blindfolded. I will stand to the side to make sure that they have their eyes closed as they do that. If you're worried about that, and especially with my youth athletes, I will have them wear a pair of completely darkened out sunglasses so they can't cheat and have their eyes open or squinting as they're going through that testing. Before we get on to a few other topics, is there anybody that has any questions? I'll open it up for about 30 seconds and I'll get a drink of water here. If there's any questions that pop up, you can put those in the chat. All right, very good. So once again, to kind of summarize, so we're going to use the clinician kit motion maze that has the standardized deviation from 5 feet away. It even says that on the motion maze where we want you to have set up. We want the patient at 5 feet. The 5-foot mark is going right through the crown of their head. They assume a upright posture and they're looking at the center bullseye target. They're going to put the laser on their head and keep that focus on the center. Then the clinician turns the laser on, and then we calibrate it down to the middle with the motion guidance laser. Once that's on, we have them do 1 practice rep, cueing them not to move their torso. There was a follow-up study, I believe in 2017, where they did the torso has the laser pointed at the target, so there was no lack of dissociative movement between the cervical spine and the thoracic spine with rotation. But we have them go through 1 full repetition to a side with their eyes open, and they come back to the center target. From there, we do eyes closed. They go through rotation as far as is comfortable, and they come back to the middle, and we record their data after they say they think that's the middle. You can do up to 6 repetitions. If they have 3 or more repetitions that are outside the standard deviation, they have a diagnosed joint position sense error for the head neck. Then we do the other side. We recalibrate. They go through 1 practice repetition, and then they come back. Okay. There is nothing in the data that I've read that is suggestive of which side is going to be positive. We haven't made that link yet. We haven't studied that extensively, though. So if you're thinking, well, they have a right-sided range of motion limitation, that's part of the challenge there. The people that were studied all had full range of motion, so we have to adjust for that. So you might want to do treatments to establish that they have full range of motion before you do this testing, but that would just be an encouragement, not defined in the literature. We also have nothing that says that we have a definitive need for doing flexion extension if they have a joint position sense error, but we do have some preliminary data that suggests that people do have a flexion extension error. So working through flexion and extension can be appropriate, as well as rotation. We also have considerations for especially our athletic population, or maybe based on work environments or specific symptoms, that we can have them do joint position sense errors in quadrant positions. This might be due to maybe some decompensation pattern that you notice in different parts of the brain or with different other regulatory systems. That might lead you there, and that would be appropriate as well. All right. So that concludes the quick and dirty for the joint position sense error. I'll take a couple more questions. Here's one from Vicky. If 2 is inside the circle and 1 is within the standard deviation, is 3 reps enough? So if 2 is inside the circle and 1 is within the standard deviation, so make sure I understand your question there, Vicky. So anything that's inside the circle is considered inside the standard deviation for normal. So you're going to have 3 that are outside of that circle in order to have a positive for a joint position sense error. So if you do have 3 that's outside the circle, then you can stop there because it's not going to get any better than that if they have 3 consistent repetitions. So if we refer back to that video, the patient that I was showing you had 3 positives for outside the standard deviation. And then he went ahead and did a 4th outside of my cueing there. And I said, no, you can go ahead and stop. Let's go ahead and do the other side. And then he went ahead and did the left side and came back. Like I said, he had some familiarity with the test because we had done that before. So he was kind of rolling out. But I wanted to show you a recent video that kind of demonstrates the technique on a true patient and what we're seeing there. You can go to motionguidance.com and check those out. We have the new generation clinician kit. We have the motion maze that's being sold separately. We have other sticky targets that you can utilize. If you need an extra laser, you can pick another one up there. And we ship to most places internationally. So thanks for joining me today, guys. And if you have any questions, go ahead and hit us up on the website with other questions, or you can look us up on social media with Facebook and Instagram. Those are our primary modes of communication. And we'll see you in 3 weeks for another topic. All those are listed on the website as well, and we hope to see you there. Thank you very much.